But just before you start, can I ask the audience, who uses off-pump CABG as their default strategy, in other words, in the majority of their cases? And who uses on-pump as their default strategy? So that means a lot of people are using neither, or they're not doing these operations.
They're using PCI.
Using PCI. Thank you, the cardiologist, yeah. Thank you, Massimo. It was about 50-50, so.
Okay. May I have my presentation, please? My presentation.
Could we have the next presentation, please?
Cleveland Clinic's blocking the system now. Can we get Dr. Lemma's presentation, please?
They're working on it.
While we're waiting, I would just make one comment. I was one of the people who heavily criticized the Ruby trial.
Okay.
Oh, sorry.
Okay. Thank you very much for the opportunity to, let's say, expose my opinion on off-pump surgery. I have to say that your presentation was really balanced because I do believe the same. We do not have to choose only one solution for our patient, but we have to tailor the ideal solution to every single patient. And let's say that off-pump surgery back in 2000 was, let's say, one of the most important developments since the introduction of heart-lung machine. But nowadays, we are not able to say that it is really this important development. I want to draw your attention at least on three main points. The first is that probably the quality of the randomized clinical trial that we have so far are not able to show that off-pump surgery is the ideal solution because there is an inherent bias within these studies, and I will try to show you why I think so. And then I think that off-pump surgery can really give, in at least two conditions, in high-risk patients and in patients with a diffuse ascending disease on the ascending aorta, the ideal solution for myocardial revascularization. These slides come from the experience of Paul Serjean. You see that at the beginning of his experience, the mortality rate at 90 days was 3.2%, and after 3,000 patients, more or less, went down to 0.5%. So these are hard endpoints, very good results. The problem is that our community usually do not believe in retrospective analysis, and we believe only in randomized, prospective randomized clinical trial. This paper was published in the British Medical Journal in 2003, and Smith and Pell were kidding the fundamentalists of randomized clinical trial because they were trying to determine whether parachutes are effective in preventing major trauma related to the gravitational challenge. They couldn't find any prospective randomized clinical trial, so they, let's say, concluded at that time that fundamentalists of randomized clinical trial should enter as participants a prospective randomized double-blind trial on the safety of parachutes. The problem with randomized clinical trial is that if they are not well designed, we can end up with results like the results of the Ruby trial. When you look at the conversion from off-pump to on-pump, 12.4% is simply unacceptable. It's not a good result. This means that probably the surgeons enrolled in this study were not able to do off-pump surgery well. We do not need in surgery simple randomized clinical trial. What we need are expertise-based randomized clinical trial. There is a difference between randomized clinical trial in surgery and randomized clinical trial in medicine. When we look for the, let's say, the effectiveness of a drug, it's not important how we give the drug to the patient. But when we look at the effectiveness of a surgical technique, it's extremely important that the technique must be applied precisely and perfectly. So what we need are studies where we do not have a single pool of surgeons doing both the technique, but interventions are performed only by clinicians with expertise in the procedure, which reduces both bias and ethical concerns. We've done a study like this, and we have published this study in the journal Thoracic Cardiovascular Surgery, and I remember that Joe in Philly was my discussant. In this study, we prospectively enrolled 411 patients, high-risk patients with an additive euro score greater or equal to 6, and the study was expertise-based. This means that consultants were trained both in extracorporeal circulation and off-pump, but at each side, randomization was expertise-based. There were two different pools of surgeons in each center, surgeon for the off-pump procedure, surgeon for the on-pump procedure. For sure, we had to give a threshold in terms of expertise, and the threshold was 250 patients minimum. But I have to say that in the vast majority of the centers who entered the study, at least in my center, I remember my numbers at that time, they were 625. Now, a very brief digression on what is an expert. How we can consider a surgeon an expert. This is what we found in the literature. You have heard about the rules of 10,000 hours. An expert is somebody, a performer, and the difference between an expert and normal adults reflects a lifelong period of deliberate effort to improve performance in a specific domain. Probably expertise is not 70 operations, 100 operations, 120 operations, but it is a moving target. It is something that is changing every day and that we can improve progressively. In fact, what we have to do is to practice following the rules of deliberate practice. Because when you live in a cave, you are not a geologist. So this means that we have to have a considerable, specific, and sustained effort to do something we can't do well or at all. So we have to push ourselves out of our comfort zone every day in order to improve our performance. Going back to our study, so prospective, randomized, multi-center, expertise-based clinical trial in high-risk patients. The results of the composite endpoints, operative mortality, myocardial infarction, stroke, renal failure, reduced for bleeding, and ARDS, was 5.8% of CAB versus 13.3% extracorporeal circulation. At 1 year, cardiac death is in favor of OPCAB, 1.5% versus 5.1%. Repeat revascularization is not statistically significant, but there is a trend, 2.6% versus 0.5%. And when you look at the crossovers in this study, you see the difference. OPCAB versus on-pump, 3.8%. You remember the numbers of the Ruby trial, of the GOPCAB, at least 7.9%. 12.4% in the Ruby trial is simply unacceptable. So 3.8 to on-pump, 7.8 to off-pump. And now it is interesting to understand why 7.8% of patients crossed from on to off. Because they had a diseased ascending aorta. 13 of them had a diseased ascending aorta, 11 calcification of the ascending aorta into dilation and thinning of the ascending aorta. And when we go back to the syntax trial and we look at what happened in terms of cerebrovascular accident at one year, we see that we pay a price of 2.2%, and we pay a price immediately after the operation. So this means that something happened here. And this something is related to the fact that in the syntax trial, only 15% of patients had an off-pump procedure. The vast majority received an operation on pump, single mammary on LAD, and a piece of saphenous vein placed on the ascending aorta. And when the ascending aorta is like this, it's not a surprise if the patient has a cerebrovascular accident. The only thing that we can do in order to save the brain of the patient is to go for an aortic CABG. An aortic CABG means an op-cap procedure with a wide-guard connection. So the inflow for the left ventricle is only the left internal mammary artery. This is what the results of the procedure, left internal mammary artery, and then the radial or the right internal thoracic artery in wide connection. It is important, yes, it is important. If we look at the demographic future in Europe, we see that the percent of people older than 80 will go from 3.4% in 2000 to 11.8% in 2050. So probably we are going to have lots of people with a disease ascending aorta requiring surgical myocardial revascularization. There is evidence in the literature about the aortic CABG. Yes, there is. This is, it's not a randomized clinical trial. It is a retrospective study. It has been published recently on the Journal of Thoracic Cardiovascular Surgery to 12,000 patients. 12.8% no-touch aorta, 12.8% with the heartstring, and 74.3% with the clamped ascending aorta, 20% on pump, and 53% off pump. The average rate of cerebrovascular accident was 1.4%. And what happened? Well, the difference between no-touch and clamped was significant, no difference between the heartstring and the clamped ascending aorta. Authors conclude that no aortic touch has the lowest risk, and that clamping the aorta increases the risk regardless of the severity of the aortic disease, because they did also an epi-aortic scanning during the operation. Second evidence, this is a meta-analysis of different studies, and you see that in patients receiving an off-pump procedure, anaortic versus side clamp is 0.29 versus 1.34, and anaortic off-pump versus on-pump 0.41 versus 1.97, and the difference is statistically significant. So in conclusion, I think that op-CAB can be routinely performed without patient selection by expert surgeons with optimal results, and that in order to be expert surgeons, we have to follow the rules of deliberate practice. So we have to keep in mind that we want to reach a target and apply our efforts in order to reach this target progressively. There is evidence that op-CAB surgery is an advantage for high-risk patients. At least our experience shows that it is an advantage. And for sure, I think that the off-pump procedure with no-touch aorta is the only way to reduce the event of stroke, postoperative stroke, nearly to zero. Thank you very much for your attention.